From the American Academy of Pediatrics.
When pediatricians prescribe stimulants, sedatives, and opioids, we need to consider all the ways they might be used.
That includes diversion of the drugs when our patients sell them or give them away.
Non-medical use of controlled medications is fairly common, and certainly a topic that pediatricians should be aware and should feel empowered to discuss with families.
Plus, medical jargon is rarely helpful, and a new study shows it can even be harmful.
The hardest to read were the kids that said being put to sleep. The two children equated that with the way their dog had been killed and assumed that if they were told to be put to sleep, it meant they were going to die.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about non-medical prescription drug use.
Joanna, here's a personal question. Do you and Danny have any DEA-controlled medications in your home?
No, not currently. With really young children in the house, I get anxious about the thought of an unintentional ingestion. And I've had to call poison control in the past when my 2-year-old got into an open bottle of liquid Tylenol. All was fine, but as a result, our medicine cabinet is very bare bones.
Yeah, I still remember when Christy opened our medication box and realized that we had not only about a dozen bottles of leftover pain medication from various people's surgeries and also stimulants from failed trials of ADHD treatment, but we also had a house full of teenagers. So fortunately, my hospital pharmacy has a safe drop box that you can use to just drop off medicines and not flush them down the toilet. So I brought in this whole plastic bin of medicines and dumped them right into the steel box.
That's a great way to dispose of them. And I know a lot of hospitals, pharmacies, and communities have drop-off events as well. And as pediatricians, we all know how dangerous misuse of these medications can be.
And today, we get to talk with someone who knows even more, Dr. Nicholas Chadi. Dr. Chadi is a clinical associate professor in the Department of Pediatrics at the University of Montreal Medical School and a pediatrician in the Division of Adolescent Medicine at St. Justine University Hospital Center.
He's also lead author of a clinical report from the AAP Committee on Substance Use and Prevention, Non-Medical Use of Controlled Medications by Adolescents and Young Adults. Dr. Chadi, welcome to the show.
Thank you.
So what substances are we talking about here? Does this include Benadryl or Robitussin or only prescription medications?
Yes, for the scope of this clinical report, we are really focusing on prescription medications, falling generally under the categories of opioid medications, stimulant medications, or sedatives. And those are included because they have some misuse potential as classified by the DEA.
And are there trends in this medication misuse that we can point to? And please tell me that at least some of them are good news.
Several trends. So one trend that we could consider good news is that today, fewer young people are misusing opioid prescribed medications than they were, say, 10 or 15 years ago. So certainly increased awareness among pediatricians and physicians as to the misuse potential of these controlled substances. Rates of non-medical use of sedatives and stimulants have been mainly stable over the past decade, with some regional differences. So really looking at more specific contexts where some of these substances or medications may be more available than in other places will have some impact. One very important trend to mention, however, which I would not consider in the category of good news, is that a lot of these substances and medications that are circulating are becoming very potent. So we are actually seeing an increase in use of synthetic opioids or sedatives that are so strong that a single pill could be lethal if taken by a young person.
And where are these drugs coming from? Are young people buying them from friends, behind the school, or off the internet, or are they just rummaging around their family's medicine cabinet?
Certainly all of the above. So social sources, certainly very common. We can think of psychostimulants, ADHD meds, which really do circulate in high schools, colleges. And so young people may have access to those through friends or networks of peers. But also, as you mentioned, medication cabinets at home. So leftover medications from family members can certainly be an easy source of access for some. So it's really a combination of all of these. And then sometimes ordering through online sources, we know are quite extensive across the country.
And what is it that drives young people to misuse controlled medications?
Several reasons. And so there is a lot of talk and discussion around use or misuse of these substances on social media. And perceptions certainly can change depending on the type of medication. So some young people may be trying a prescription stimulant that hasn't been prescribed to them in the hopes that it would help with academic performance. Some people may be dealing with symptoms of depression or anxiety and think that using a sedative would help calm them down or perhaps feel better. And some young people may have pain and think that using an opioid would be helpful. And then could fall into a pattern of using for other reasons, including potentially getting a euphoric effect from it. And because of the addictive potential of these controlled substances, then a pattern of substance use and sometimes addiction may happen after that.
And what young people are most at risk for this happening to them?
So there is a long list of common risk factors when it comes to substance use. So past family history, mental health history, socioeconomic status and demographic factors, being part of sexual and gender minority places you at higher risk of using substances. And so there are some common factors to all types of controlled substances. And then there are some more specific ones depending on the projected or felt effects of these substances. And as I mentioned, some reasons may push you to use or to try some of these medications, and those may be linked to the information that young people have related to them. Certainly, one factor that has been identified as a risk factor is being prescribed prescription opioids, for example. And if you are prescribed these medications in greater amounts that you may need, and they then may have leftovers, then there is a risk that may lead to non-medical use later on. And, that would be true with pretty much any type of controlled medication that isn't being prescribed with decent follow-up and regular support surrounding the prescription of these medications.
So are these risk factors more individual, or are they related to societal factors?
That's actually a great question. So there's nothing to say that the fact of being a certain race or ethnicity or having a certain sexual identity will directly link to misuse or non-medical use of controlled medications. We have to think more broadly in terms of societal stressors and factors that impact people of different race, ethnicities, or backgrounds, and related to these risk factors I mentioned.
And are there any signs or symptoms, either acute or long-term, that should alert us to the possibility of non-medical use of prescription drugs?
The answer is yes, but also when we think of substance use in general, this may present with very non-specific findings. So a young person who may be having less motivation to engage in schoolwork or sports or extracurricular activities, who may have a change in their peer group, who may just be more isolated, may be using substances, but may also be having all sorts of other things, such as mental health issues or dealing with social or psychosocial stressors at home. So certainly it's hard to say, one thing would lead to another. But certainly if there's a change in general interests and energy levels and general functioning, I would say, this would be something to watch out for.
And what can we as pediatricians do to address this problem for families and young people?
Well, the first thing I will say is that there is good consensus that pediatricians should screen for substance use in all young people starting around age 12, the age where substances start being used more commonly at a population level. Any clinical encounter is an opportunity to see and ask if young people may be using substances, and also being, involved with non-medical use of controlled substances, using validating tools, which may be very short. I'm thinking about the CRAFT tool or the S2BI, for example, are definitely great examples of ways of doing this relatively quickly. And then whenever prescribing any controlled medication, having a conversation about the potential for misuse. Pediatricians should prescribe psychostimulants for ADHD, but should also make sure that they're able to follow up, that the dose is well adjusted, and also that other issues or comorbidities are addressed. So if you are prescribing a controlled medication to someone who has untreated mental health issues, then, there is a risk that this may lead to other things. So really, you want to make sure that you're addressing, health more globally when thinking of these medications. And then certainly, when thinking about prescribing an opioid, or even if you hear about potential misuse of controlled substances, prescribing or recommending naloxone. Naloxone can be found for free without a prescription, but prescribing it will sort of give it a strong message that this is something that can save a young person's life or, other people who may be dealing with non-medical use of controlled substances or substance use disorders.
Nicholas, say one of those screens comes back positive. What now? How do we support these patients?
Of course. So just like we would for young people who use substances, we would really want to make sure that we're bringing the screening process a little bit further, understanding why young people may be using these substances, what are the effects they're seeking, and whether or not there are underlying medical or mental health conditions that haven't been addressed. If the issue is severe, if there is regular use of these controlled medications, we want to make sure to direct young people to appropriate services. Young people should have access to all different treatments that are also available to young adults or older adults. So making sure these connections are made, that there's a good understanding of the problem, and that young people feel heard and comfortable speaking about these issues with you as a pediatrician and with other sources of help.
And following up on this positive screen and supporting the child, what role do parents play? And in what ways should the pediatrician involve the parents?
Certainly, parents have a very important role in addressing the issue of substances in general in the home, having non-judgmental conversation about it with younger people as they age, so that we can share, thoughts and input about how to be safe around use of substances and ideally delay use as possible or not use at all when we're young. If it is an issue and then parents are not aware, and as a pediatrician, you hear that a young person may be putting their life at risk because they've had an experience with non-medical use of controlled substances. Well, if there's a risk to the young person's health and they're underage, parents need to be notified. There's often a gray zone, however, if it's happened maybe one time, it didn't seem to be life-threatening, what should be done? Laws, regulations may vary by state in how to deal and manage these issues, but in all situations, if parents are there and supportive, working with a young person to see how we can disclose to parents so they can be allies in the issue, they can help bring more positive and healthier behaviors, really is the way to go. And being transparent with the young person about why we would involve parents and making sure we're not disclosing to parents without telling the young person to maintain trust and therapeutic alliance.
Nicholas, this is such a thorough and compelling report. Do you have any takeaways you want to make sure our listeners remember?
Absolutely. So one thing is for sure, non-medical use of controlled medications is fairly common, and certainly a topic that pediatricians should be aware and should feel empowered to discuss with families. There are several small things that pediatricians can recommend and that can really go a long way in preventing this from happening. And this may start by speaking with young people and parents about managing leftover medications, making sure they're being disposed of correctly, making sure that controlled substances are kept in a safe place, locked away if possible, that there is some discussion about potential risks related to diversion, selling, giving to others your own prescription medication. So really all these small things and small steps that pediatricians can do in everyday practice can really go a long way. That, and I will say, trends change. When it comes to substances do evolve with time. So it's good to keep an eye on what the trends are and what emerging risks may be.
Dr. Nicholas Chadi, thank you so much for joining us today.
It was a pleasure speaking with you.
To read the clinical report, Non-Medical Use of Controlled Medications by Adolescents and Young Adults, go to aap.org/podcast.
Coming up, we'll look at how medical jargon can cause confusion for our patients and their families.
David, did I ever tell you the story of when I asked a mother how long her child had emesis?
No, but now I'm really curious to hear.
Honestly, David, I just told you it. I asked about her child's emesis, and she just looked at me. And as she was staring at me, confused, I realized that she had no idea what emesis was.
Well, yeah, how would she know that means throwing up? But it does work both ways. My dad loves to talk about how, being from the South, when he was in residency, he was the only pediatric resident in all of New Haven who knew that bowels running off means diarrhea.
The terminology we use in medicine is a language we learn in training, and it doesn't exactly translate to our patients. We're aware of that when we talk about medical jargon, but what is it really? I'm so glad today we have Doctors Rheanne Maravelas and Michael Pitt here to explain.
Dr. Rheanne Maravelas is MedPeds like me. She is an assistant professor of medicine in the Division of Hospital Medicine at the University of Minnesota, where she researches communication surrounding advanced illnesses.
Dr. Michael Pitt is also at the University of Minnesota, where he's a professor of pediatrics, associate chair for faculty development, and the director of the Pediatric Hospital Medicine Fellowship Program. He also did an episode with us about magic in medicine that I hope you will go back and listen to. It's episode 13. Doctors Maravelas and Pitt, welcome to the show.
Thanks for having us.
Thank you.
So, Joanna mentioned the term medical jargon. Rheanne, in this paper, you use the phrase jargon oblivion. Can you explain what we're talking about here, please, using clear, common language?
Yes. So by jargon oblivion, we mean when physicians or other healthcare providers use terms that really are jargon, they're specific to medicine, they aren't understood outside the medical community without realizing they're doing so. So basically using terminology that their audience doesn't understand and also not realizing they don't understand it.
And Mike, are there common types of jargon we use in medicine? Like when I use the term emesis with a family, is that a common faux pas?
Yeah, it's a great point. I think the key here with jargon oblivion is because we forget we learned these words. If somebody says to us, don't use jargon, we think, I'm not. I know what febrile means. I know what emesis means. We're not trying to confuse a patient the way that maybe we feel happens when we go to a mechanic. You know, when we go to a mechanic and they start talking about pipes and fluids, and it stresses us out and we feel they're weaponizing their language to run up the bill. Believe it or not, we've actually surveyed families and they feel that doctors can be doing the same thing sometimes. We're giving ourselves the benefit and saying we are just oblivious to this. And so a colleague and I, Marissa Hendrickson, and later Jordan Marmette, put together a category of 7 types of jargon. And I would say emesis is that first category, words that you definitely learned in medicine, medical technical terminology that you just forgot you learned in medicine. But those other categories include acronyms and abbreviations that mean different things. I was 2 years ago when I learned that ASD also meant autism spectrum disorder. And I kept thinking, why do these notes say that this kid goes to a special school for their heart ASD? You know, do they not scuba dive? Like I was confused about what was going on there. Medical vernacular is that third category, words that people have heard on TV shows, but when we really ask them, they don't know what they mean. 0% of teenagers knew that what febrile meant. 9% of adults. They thought it had to do with how much fiber was in their diet or if they were fertile, for example. And then unnecessary synonyms is that fourth category. That's where we're saying a word that has a perfectly good English definition, arm, and we say upper extremity. Or we say, instead of red, we say erythema. And we're just adding language that's unnecessary to confuse people. Those last categories, medicalized English, words that mean something already in English and now mean something different in medicine. When we ask people at the fair, if the doctor told you your tumor's progressing, is that good news or bad news? 21% of adults thought that was good news because progress in every other world is good. So progress, negative, positive, appreciate, diet, these all words mean something different in medicine. And our last two categories, euphemisms. So we have a hard time using the word death. Even when my own dad died and the nurse called me and said, "We lost your father," I took that as good news because it meant he was well enough to get out of bed and get lost. So, just the reality of how these words land when you're not in that medical context, even as somebody who studies jargon. So euphemism, spot on the x-ray, bugs in the urine, things like that. And then the last one we call judgmental jargon. And these are words like non-compliant or denies alcohol use, words that carry a loaded meaning if you're interpreting it incorrectly.
And Michael, does any of this research on use of medical terminology come from the pediatric population? I like to think that because we're used to talking to kids, maybe emesis notwithstanding, we're a little better about this?
I'd like to say so. That's what we're here for, is to share really the first study we did with kids. The short answer is there's not a lot out there. I think Rheanne can tell us a little bit about what we did in this particular study. My colleague, Dr. Hendrickson, texted me yesterday and said, "Oops, I said to a patient, I've got some vomiting medicine for you." And the kid started to cry because she thought it was going to make her vomit. So even those of us that are doing the work here have the work to still do.
Okay, so you asked children about different medical terms. Rheanne, how did you know which terms to choose?
Yes, so our Clear Clinical Communications group at the University of Minnesota has done a number of prior studies with adults. And with this interest in exploring what children understand, our group got together and thought of common terms that people use around the emergency room and hospital mostly, because our group consists mostly of emergency physicians and hospitalists. And we chose to focus on words that we thought that the doctors might not necessarily think about as being very jargon-filled, but with the prior background, especially on medicalized English, we thought that maybe the children would have a very different idea of compared to the clinicians.
And so knowing you went through all this work to get these medical terms to use, can you give us some examples of what they were?
Yeah, so we asked about negative and positive test results. We asked about drawing some blood, putting to sleep for, a procedure, getting a CAT scan, some phrases about moving around in the hospital, such as the hospital not having any beds or being transferred to the floor. Questions about doing a test, putting in an IV, placing a diet order, having a surgeon come see the patient.
Okay, guys, I am really curious now. When you asked kids about these words, what did they say? Rheanne, you want to start?
Yeah, absolutely. So first off, the kids actually had really good understanding of negative and positive test results. Over 80%, 85 and 82% understood negative COVID and strep throat tests. We wonder if maybe the extensive talk about these sorts of tests with the pandemic might have helped. But anyway, the kids really did well with negative and positive test results. Most of the other questions generated a lot of confusion and a lot of variable answers. Over 60% correctly understood drawing blood and putting to sleep for a procedure, all the way down to less than 9% understood having the surgery team come see you meant a consultation seeing in the room, whereas most actually thought that they were going to be taken for an operation that day.
And Michael, this paper includes some examples of interpretations of CAT scans. Can you share those with us?
Yeah, the funny part was, of course, some people thought that meant cat, and not just that a cat would be crawling around in the machine. We had, I believe, 4 children think that cats were involved, but them actually attributing the cat's characteristics to what would make it a good diagnostic test, that saying that cats have good senses of smell and vision, and maybe that will help them get to the answer. And so, of course, some of these are funny. Even the fact, when you have that initial reaction of somebody saying, "Oh, if I heard they were going to put a diet order, I thought it meant they were telling me to be on a diet." But when you then had them say, "I thought it meant the doctor thought I was fat," you really go, wow, that passing comment could actually really stick. and cause stigma. Or, of course, the hardest to read were the kids that said being put to sleep. The two children equated that with the way their dog had been killed and assumed that if they were told to be put to sleep, it meant they were going to die. That's something that's not innocent. I mean, we need to be aware of even the stuff we don't think of as jargon. And even if we're not saying it to the child, we're saying it and the child is listening. They are making interpretations that being transferred to the floor means they have to give their bed up and get a sleeping bag.
Well, this seems like a very pro-cat and anti-dog study. But if we are confusing and even scaring kids with our medical speak, what can we do differently to help support them? Rheanne, do you have any ideas?
Yeah, so one of the things that became apparent as we were talking to these kids at the state fair is that children as young as 4 years old included in this study were pretty concise and direct with giving an answer. You know, even if we don't think about it, these children are interpreting what people are saying. And if you just take the pause to ask, they were pretty willing to give the answer of what it was they thought. So one of our conclusions from doing this work is that just taking that time to ask, teach back, which has been well established in other situations, can be really valuable with children. Especially there's so much variability between what different children may understand from a given phrase. You know, making sure that the child in front of you knows what's going to happen to them can be really important.
Well, this, in addition to being amusing, is actually incredibly thought-provoking and helpful for all of us. Drs. Maravelas and Pitt, before we let you go, we're going to need one takeaway from both of you about this work, something that stuck with you and that you want listeners to know before they read this paper. Dr. Pitt, can you start us off?
Yeah, just that this jargon oblivion is all of our problems, that we actually need to recognize that we could be the smartest clinician in the world. And if we're not clearly communicating with our patients, we're useless. If they don't understand the plan, we're useless. That goes with our kids and our adults. And these words can land to often mean the exact opposite of what we intend. One of my favorite stories was a person coming up after we gave this talk and saying, you know, I read a report of my CAT scan and it said testicles were unremarkable. And he said, for years, I was insecure about this, thinking, why are my testicles unremarkable? I want remarkable testicles. And ultimately went to medical school and went, oh my gosh, that was just normal. You know, these words carry weight, whether or not it's intended or not. And it's actually why we went into medicine, was to communicate with patients. And we should take that really seriously.
Indeed. And Dr. Maravelas.
Yeah, absolutely. I agree. Doing this work, hearing from patients, hearing from families, so much of our work, it's easy to think of as being the diagnostician and writing orders and deciding on medications. But really, that role of communicator and educator to the patient and their family is so critical. Because when that patient leaves, when they go off, they're the ones who are interpreting what's going on with their body, who are carrying on, seeing specialists, taking care of their medical needs. And one of the most important things we can do for them is to make sure that they understand what's going on and have the knowledge they need to effectively manage their health conditions.
Well, Drs. Pitt and Maravelas, thank you so much for joining us today.
Thanks for having us.
Thank you so much.
I had a truly positive experience.
Us as well.
It wasn't unremarkable, though.
Yeah, it was remarkable. To read the paper, Children's Understanding of Commonly Used Medical Jargon, go to our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Mine is to say, ooh, ah, because here in Wilmington, North Carolina, in our coastal community, in the South, we have snow on the palm trees. Joanna, it's been over a foot overnight. It's still coming down. The dogs have romped in it and been extremely confused. I'm building a snowman later today. It is crazy for this part of the country.
Are you a classic snowman build? You going to do the top hat, scarf, carrot?
I have to find my top hat. I think I had it cleaned after I wore it recently.
And that's David's fashion, everyone. My say is about snow as well, because this past weekend I actually took my kids to the park in Syosset, where I grew up and went sledding as a child. And there's this like really awesome hill there. And I was so proud of them because they were so brave. It's bigger than any hill in Philadelphia. And they were sledding down it, having the best time. There was one epic wipeout that I have on video. But otherwise, it was a grand old time. And it just reminded me of the fun I used to have there as a kid.
Oh, that is spectacular. If there were any hills in this neighborhood, I'd be on them right now, just like your kids. But it is totally flat. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll get a research roundup from Dr. Alex Kemper.
We'll also talk to Dr. Sue Cressley about pediatric acute onset neuropsychiatric syndrome, or PANS. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.